involvement in cancer prevention and control started one day in 1988. I'd been working at the CDC for 6 years and had the good fortune of getting to know two luminaries in the state, Paul Carbone, who was the head of the Cancer Center, and also Henry Anderson, who was a leader at the State Health Department. There was a grant from the National Cancer Institute that Dr. Anderson had written and gotten, and it was called Data-Based Intervention Research for Cancer Prevention and Control. And this grant involved looking at the data, forming a coalition, developing a plan, and implementing the plan. And my job was to get that grant off the ground. And the first thing I did was read the grant, and I looked at the plan, which involved developing a coalition and a coalition process to look at cancer in the state. And I did that. I called up everybody I knew. I said, let's form a coalition, not realizing that Paul Carbone already had established Wisconsin Cancer Council. And so he was a little off-put by the fact that this young upstart at the State Health Department was forming a competitive coalition. And I said, absolutely not. Let's put our coalitions together. Let's form a single group and begin working. And we did that, and it was an amazing process involving the American Cancer Society and all of the various partners in the state. And our job was to pick a priority for the state to work on. We can't, in cancer prevention and control, pick just one priority. So we broke the rule or bent it really, and picked two priorities. And those were cigarette smoking prevention and control, and also breast cancer screening. That first decade, during the 1990s, set the stage for the coalition model, set the stage for a focus on prevention and early detection. And then it evolved. I think the benefit of the coalition model is that provides a convening of people with common goals, which is improving the quality of life, by using diverse methods. Prevention is a very different approach than early detection and treatment, and we need that comprehensive approach.
The Wisconsin Well Woman Program is our state's component of CDC's National Breast and Cervical Cancer Early Detection Program. Since June of 1994, the Wisconsin Well Woman Program has provided services to more than 85,000 women across Wisconsin. When we first started the program, there was no treatment component. Of course, now Well Woman Medicaid is our treatment component. And the wonderful thing is that we work very well together. Obviously, Well Woman, we provide the actual screening and diagnostic services for breast and cervical cancers. But if a woman is diagnosed with cancer as a result of her screening through our program, then there is the treatment component, Well Woman Medicaid. We can provide services to women who prior to our program couldn't get these services because they were uninsured and they did not have a lot of financial resources. And so that's one thing that's very, very, very important. The other thing is the partnerships that we have that help us to do what we do. We are a statewide program, and our coordinating agencies in our local communities are really the backbone of the program. They are the ones who talk about the program at the local level. They are responsible for case management, that is, making sure that the client gets what they need through the program. We're particularly proud of our patient navigation component, and I have to say, we just really want folks who come through our program to, be safe, be healthy, and again, know that, if you don't have the means for screening and diagnostic services, we are here. And that's important. I think that's very important.
it was a 2-year process to write that first plan, and we were starting from scratch. So I commend all of those partners that came together. We had 200 people that trusted us and brought their voice to the table. And I think we ended up with a really strong product. People from around the state care about cancer control. They want us to do the best that we can for our neighbors, our communities, and patients. They were willing to come to the table and set aside the different organizations or types of cancer that they represented and think of this holistically across a continuum. And that was really new for the time. 20 years later now, it's the way we all do business here. When we first created that plan, I'll never forget Dr. Doug Redding from Marshfield Clinic said to us, I don't want this to be another plan that sits on the shelf. I don't want to be a part of something that is static. And I think we have stayed true to that mission over 20 years where it is not static and it's alive because of all the people that care about it and all the people that make sure that we are staying true to what we're trying to do with that cancer plan. The pride in the work that continues today and the evolution with the cancer plan changing over time. We've planted deep roots and it continues to bear fruit for our friends, neighbors, and patients in the state yet today.
My career really extends through the entire phase of the recognition of HPV as a cancer-causing virus to a point now where treatment is really evolving in head and neck cancer particularly. I think it's fair to say I went into ENT, ear, nose, and throat, because there were certain parts of the body I had no interest in discussing throughout the course of my career. That changed, right? I began my practice in 1987, and it was only the year before, or 2 years before, that HPV was clearly identified as the cause of cervical cancer. So it was just really beginning at that point. Oropharynx cancer didn't really become part of the conversation until the late 1990s. And that's when we were noticing that we suddenly had this new population of people with oropharyngeal cancers that were much younger, that did not have the traditional risk factors of tobacco and alcohol use, and the fact that they did remarkably well in treatment in ways that we didn't really expect. The vaccines became available in 2006, recommended for girls. A couple years later, they were recommended for boys. And mostly at that time, it was to prevent cervical cancer and genital warts. It really had nothing to do with oropharynx cancer, at least its initial indications, really until much later. So when HPV-related oropharynx cancer became something of which the public was aware, we suddenly had a lot more questions and people wanted to know what it meant. Because there was so much awareness, first of all, that HPV was a risk factor, but second of all, that there was something that we could do about it and hopefully prevent the cancer from developing. This was truly a cancer vaccine. So I think that was something that we learned to talk to our patients about, and not only about our patients, but they would come in and ask about, what should I be telling my grandkids? What should I tell our daughter about what she should do with her kids? Is this something worthwhile? And there was a lot of discussions about the benefits of vaccination. I think some of those maybe have eased a bit as people have become more comfortable with it. And I think as the benefits, particularly in cervical cancer, have already been demonstrated. You know, I'm hoping that my great-grandchildren read about HPV-related cancers to oropharynx only in the history books. And it's entirely possible if we get a deep enough penetration into the population of the vaccinations.
The Wisconsin Pink Shawl started out of 4 of the board members for Indian Summer Festivals, all having had experienced breast cancer. We had a platform at Indian Summer to present that to the community because Native women felt this was not a Native woman's disease, that it was a white woman's disease, and we didn't have to worry about it. Started as a grassroots group to get out the word in regards to the importance of screenings, early detection, and there's no shame in coming forward and saying, yes, I have had breast cancer, which was kind of a cultural deterrent. People felt if you talked about it, once it was spread through the community, you were not going to be talked to. We hope to engage communities on an ongoing basis through the Share the Care Indigenous Cancer Conference. This year, we held the event at the Stockbridge Mohican tribal community and reached a large population of Native people as well as non-Native people. We hope to continue on the tradition of this conference by taking it on to another tribal community so that more and more people are reached.
I'm proud to do the work that we're doing because I noticed that when people come and have the conversation, they walk away feeling more empowered. And the fact that they do ask questions and there's curiosity, and they may come back, the following year and, I got my mammogram done, and, that there's something to be proud of. We can plant seeds to reduce the stigma and maybe have more people engage in the conversation without it being fear-based, because the reality is sometimes people just don't know where to start or where to look. And when we have that listening ear, they may be more willing to share. That just shows the importance of the impact that's being made when you're in the community.
I'm thankful for the partnerships that we're able to build on and the collaborations that the Wisconsin Cancer Collaborative has allowed us to make. If it weren't for our partnerships and the collaborative work, we would not be able to do the work that we're doing.
It's all about human interaction and engagement and community, and what can we do to work better together? And I think all that can lead to better outcomes.
"24 years ago, when I was diagnosed, it felt kind of like I was done with treatment and I was launched into the wild, wild west. Go take care of yourself, kid." In the time since then, most folks, or I should say a lot of folks, are getting care plans when they're done, which gives a survivor the empowerment to pay attention to their own situation and their own, like, what do I have to worry about and what don't I have to worry about? Because for the most part, as survivors, once you get done with treatment and you're kind of launched out on your own, you kind of worry about everything. People are asking the questions of, how do I do my work? What does my future look like? What can I no longer do? What can I do now that I didn't give myself permission to do in the past? How do I manage my family? What impact will this have on my family? Will I be around in 5 years? When I got my job here, that was one of the questions that they asked. Where do you want to be in 5 years? I'm like, well, I was 5 years out from my diagnosis. I was like, well, that's an interesting question to ask somebody who's a cancer survivor. I want to be here and I want to be doing this work. Gilda's Club has now been here for 17 years, and I think we do a great job of providing community for people who are in the middle of treatment and or have completed treatment or are years out from treatment, and their families, to have that community of, I am not the only person who's dealing with a cancer diagnosis. Some very staunch, independent folks that I know are saying, you know what I learned from cancer is that I don't have to do everything by myself. Sometimes what they actually need is to be around other people who are also saying the same thing. Like, this is hard. Right now, this is hard. And how do I make it easier for myself? And our hope is that we help people make it easier for themselves and on themselves, and, find that community really is stronger than cancer.
The smoke-free air laws that passed at the community level were critically important in order for us to get a statewide law. It was the teamwork on the ground that really made that happen, between having the data and information, community engagement, outreach, and advocacy. And it was because of all of that community action that legislators all over the state recognized how important this law was and how it was good for both health and business. In my work now, both with public health broadly as well as alcohol, the lessons of working and listening to communities is the number one piece. We are not going to pass the state law on our own because we have the data. That's been shown over and over again. Doesn't matter which party, what administration. What changes people's minds is being engaged and talking with their lawmakers, whether they're city council, county board, or state legislators. And engaging with them about the work that everyone is doing is critically important if we're going to move anything forward. In terms of what I'm most proud of, I'm most proud of being part of a movement that has forever changed Wisconsin and has changed the trajectory for people in their lives, especially in terms of cancer. It was great to be part of so many areas of the state, so many contacts, so many passionate people, and people that would tell their stories of cancer and other harms from secondhand smoke. So getting secondhand smoke out of all workplaces, including restaurants and bars, was really a crowning achievement for public health in Wisconsin.
The NLST was a trial that was started in the early 2000s that was aimed to determine whether screening with spiral CT examination in a high-risk population could reduce the mortality from lung cancer. Probably most of the people that would be listening to this are well aware that lung cancer is the number one cause of cancer mortality by far in the United States and in the world. So it would be very important to be able to find ways to reduce lung cancer mortality. And basically what happened in the NLST is patients were randomized to receive either a chest x-ray or a spiral CT examination on an annual basis for 3 years. And the result of that trial was that we were able to demonstrate a 20% reduction in lung cancer mortality, which is really a striking finding and the first time anything like that had been shown. I've always been grateful to Marshfield Clinic for the fact that they gave us that opportunity. In my career, the experience of being an investigator with both the PLCO and the NLST, I really considered a highlight for me. I'm just proud of the fact that what we did led to a major change in lung cancer management, and something that is going to have an effect on many, many people's lives.
About 20 years ago, there was a problem with cancer insurance coverage, and some insurers were passing high out-of-pocket costs, copays and deductibles, onto patients for pills or oral chemotherapy, which either meant patients weren't getting access or they were literally going bankrupt trying to cover those medications. And frankly, over the years, fortunately, more and more cancer treatments have become very targeted. You can take a pill at home and it's part of your treatment that works. But our laws were behind the times on that. But in 2012, two of the top most powerful GOP legislators co-sponsored a bill. It was called the Cancer Fair Treatment Act that said any insurer in this class of insurers that offered medical treatment for oncology had to match or limit the copays and deductibles to those on the pharmaceutical side of things. It had broad support. We've never seen anything like this. And to a person, including the resistant leadership, they all prefaced their accounts by saying, I'm voting for this in honor of my mother, my sister, myself. It really brought out the ubiquitous nature again of cancer. So it was overwhelmingly supported on a bipartisan basis, in part because there was a coalition of 20-some organizations most of them members of the collaborative, who worked together over the course of a year, year and a half, blanketed the Capitol and educated. So the power of grassroots, you've got to bring stories, you've got to educate people on kind of a complicated issue. We did a great job of that.
The major pivot point for me was in 2017, 2018, when our ASCO policy statement around alcohol and cancer came out. And in doing so, we really helped elevate the conversation around alcohol as a carcinogen. The information about it being a carcinogen was not new, but we were able to shine a light on it and encourage conversations. And I'm not going to say we solely are responsible for this, but there was a snowball effect where other organizations have started talking about it, now the Surgeon General as well. I just feel like it's gaining a lot more attention, certainly amongst lay people, but also in scientific communities. I'm proud to have written that paper and done the media and subsequent research efforts after that, because I come from Wisconsin, which we do have a problem with alcohol consumption here. And because I believe that by talking about it, first of all, we diminish stigma related to conversations about alcohol, but also we could be responsible for a 5% reduction in cancer in our state if we can get people under the recommended guidelines. And so that to me feels like really meaningful work, because I see every day in the clinic how detrimental alcohol can be, not only on patients, but families and communities. You know, Wisconsin is known for our problematic drinking, and I hope that by doing this work that we're also known for leading the way in alcohol control.
It was with great pride that I noticed in about 1990 that the trends in age-adjusted cancer mortality began to turn. The legacy of rising lung cancer rates in men and women began to flatten. And then we saw progress in reducing breast and cervical cancer mortality. We saw progress in reducing colorectal cancer mortality, and even recently prostate cancer mortality. The culture on smoking is dramatically different today than it was when I started working in public health. Women can get a mammogram as part of routine medical care, paid for by insurance. When I started, they weren't available. Women had to self-refer and pay themselves to get a mammogram, an evidence-based screening program. And that really is satisfying to know that while we're working in coalitions or collaboratives, and while we're trying to get evidence-based public health programs and policies into place, eventually things do change.